There's data more recently that combining BTK inhibitors with anti-CD19 CAR T-cell therapy improves outcomes. There's preclinical data with ibrutinib as well as zanubrutinib, and then there is clinical data with in the CLL portion. In those patients, there was not a lot of toxicity, but there were improved outcomes. And then in the preclinical setting, the studies showed that there is improvement in the CAR T-cell therapy itself. So there was less expression of PD-L1, which is an exhaustion marker. So because of this, we use Pirtobrutinib with the 2019 CAR T-cell therapy. The reason we use Pirtobrutinib is because it's highly selective and it has less side effects than ibrutinib and other covalent BTK inhibitors. The study we presented, it's a retrospective analysis of about 11 patients which received Pirtobrutinib at least 4 weeks prior to the 2019 CAR T-cell therapy. We showed some preclinical data, so we did immunophenotyping using flow cytometry, as well as we did isoplexis to calculate the polyfunctionality and the polyfunctional strength index, which kind of measures the cytokine release by these CAR T-cell therapies. So the CAR T product, which was exposed to Pirtobrutinib, so the CAR T product collected from patients who received Pirtobrutinib, the immunophenotype was similar, so there were similar numbers of naive CAR T-cell and terminally differentiated CAR T-cell therapy in both groups, but both the polyfunctionality and the polyfunctional strength index was higher in patients who received Pirtobrutinib prior to CAR T-cell therapy. It was not statistically significant because of small numbers, but it trended towards significance. In terms of outcomes, the overall response rate was about 82%. There was not a lot of side effects, so 2 or 3 patients had CRS and ICANS. All of them were grade 1 to 2. 3 patients had HLH, so IEC-HS, which is the HLH related to CAR T-cell therapy. And this, we think, is probably related to the underlying histology, which was mostly CLL and RT in this group.